First, we're going to discuss our target underserved group, followed by our customer profile. Then we'll go more into our solution and discuss 5 issues that we are going to resolve for our target underserved community, and then go over timeline and cost. So I'll just pass it on to Jason to talk about our underserved community.
Our first actual task was to define what rural was. Generally, it's countryside in a low populated density area. Additionally, what we found out, various agencies, state and federal, have different definitions due to research and funding. So it made it a little difficult and confusing for people who qualify for different programs. As you could see in the map graphic, the darker shaded areas are where the country is at a shortage for a whole in healthcare. And I'm just going to pass it to Sahil for the regions that person in one of the regions that we're going to go into.
I would like you all to meet Patricia Brown. She is 67. She's from Delta region, which is a rural region. And she has been serving for military for 6 years. And then returning from the military to her hometown again. She is working to provide the home care to the aged community there. She also a breast cancer survivor, and she's personally feeling the healthcare facilities have been facing the issues there. These issues can be solved. These issues can be solved with our solution, payer to provider app. I would like Jason to talk about that app in detail.
So sure, for those of you who flew in today, you probably followed the same process we did to get from Pittsburgh to our hotel. We simply just took out our phones, opened up the rideshare app like Uber or Lyft, and requested a ride. So I don't think there's any reason why healthcare access can be as simple as that. Basically, our PDP payer to provider solution is a healthcare app that's going to connect payers and providers via a range of mobile clinics that's going to bring care directly to the customer, and it's going to be at the same level as make a brick and mortar. We're going to have a simple user interface for easy to navigate and keep costs low. This is going to be on demand, real time, where you can see different clinics and doctors that are available within the area. We're going to build this on a platform for Apple iOS and Google Android to access mobile and on tablets. We're going to keep connectivity as well for any guardians or family members who want to help any elderly patients as well on this app. All that's going to be done via secure authentication. Next slide. And we're going to provide in rural and remote communities, provide a variety of care options that you can see listed here, as well as services via different levels of care in different vans and shuttles and RVs, mobile clinics. So I think the main thing we want to focus on is execution on the implementation. We're going to use Optum scale and size to collaborate across the organization to bring this to life. We're going to use the existing assets. As you see, Optum already has mobile clinics. So this is nothing new to them, but I think using this new technology in partnership with the app will really bring it to the next level. Additionally, we're going to use Optum Care's network of physicians for the staffing. We really want to have partnerships. There's other healthcare systems that use mobile clinics as well, and we hope to bring that to life by partnering with them. Last month, Optum announced a partnership with Walmart, where they're going to have clinics. So we think Walmart has a really, really good strategy to target rural locations. So I think later on in the long term, our data from our app will be able to provide some insight into where brick and mortar locations may be needed in additional clinics. I think additionally, Optum's recent acquisition of Change Healthcare is going to be able to provide some of the insights, solutions at the point of care and facilitate some of the payments. And, we're really going to quite literally drive this solution. And we're going to talk about some of the disparities next.
So as Jason mentioned, there are 5 disparities that we do want to use this app to resolve for our targeted community. The first being medical access to medical care and medication. Currently, there are multiple issues regarding this getting rural communities access to medical care and medication. And it can break down into 4 specific issues, which is lack of medical care or medical professionals in the region, long distances to just brick and mortar community or facilities, internet access. Obviously, rural areas don't have as much, and a lot of pharmacies don't necessarily accept the insurance of Medicare. So P2P would provide a solution in that it would consider the patient's insurance when connecting patients to mobile clinics and mobile pharmacies, as well as Jason didn't mention this, but we do also want to add a hotline option so that people who do not necessarily have access to internet can still phone in and use the mobile care network. And now I'll pass it on to Sal, who will talk about our substance abuse issue for our community.
Right. So, substance abuse is a continued use of alcohol and illegal drugs. So, in the right side, you can see the chart where we can see the rural areas are having the high percentage of substance use. The issues faced due to substance abuse are limited resources for the prevention, treatment, and recovery. This can be solved with our P2P solution because P2P locates nearby clinics and provides the treatment, and also it access to the mental health professionals via mobile clinics and telehealth. So now I would like to call Jason to talk about veteran care.
Thank you. So veterans who often put their lives on the line for the country historically have received less than optimal care. As you can see here, there's a disproportionate amount of veterans that live in rural areas, with the main issues limited access to specialized care. And then there's additional factors such as homelessness, substance abuse, and poverty that contribute to a lot of the disparities. Our solution hopes to bring clinics and specialized treatment out to homes for these veterans, and then additionally mobile pharmacies as well, where they can provide medication, mental health care, and things like that. So I'm going to pass it to Smith, who's going to talk a little bit about hunger.
Yeah, so the chart here displays food insecurity is prevailing in the rural areas. And according to multiple studies, food insecurity is directly strongly correlated with chronic diseases and poor health. So, but some of the issues that rural communities face is lack of food retailers that can provide fresh and affordable food, and also the lack of awareness about right nutrition. So how P2P can help here is by connecting those people with the mobile markets that are nearby, and by also providing tips about the proper nutrition, which could both be curated for local as well as seasonal advice. And these are some of the major conditions that prevail in rural areas. So P2P again here could help connect those patients with these conditions with nutritionists so that they can have a customized diet plan curated just for them. So now Sharon will talk more about complexities with Medicare.
Yes, I just want to touch very briefly on complexities of Medicare. Medicare, of course, being the national government health insurance, there are a couple issues that really do need to be brought forth. One of the main ones is that because of the complexities of the sign up for Medicare process Part B, there's a lot of issues that eventually lead to penalties being incurred by citizens, higher out-of-pocket costs, and unfortunately, it does take up a lot of time, emails, and calls for the Medicare Right Center. In addition, a lot of the medications all the household spending for medications for Medicare patients aren't usually covered because these are usually generic medications. How P2P helps in the situations that we make a more streamlined startup process to help people sign up for Medicare, to decrease calls and emails to the Medicare Right Center, but also by bringing forth low-cost, affordable medications to the forefront to the citizen. We do want to round out now with our current timelines for the P2P application of the costs. We actually split up our timeline into an initial 6-month pilot program that's going to funnel into a 5-year plan. So our 6-month pilot program starts with partnering with Optum Health and companies that already have mobile clinics on hand that we can actually use for some of the clinics that were already discussed by my colleagues. Next, in the connecting phase of the pilot program, we would recruit the necessary medical physicians, nurses, and healthcare staff to run the mobile units. Moving into the product development, which is the third phase, once the P2P application is developed, we would actually introduce it into one state in 3 separate regions to gather all the necessary data and information that we need. And once we've gotten all that information, we would funnel this into the 5-year plan. The 5-year plan does begin by building on the existing networks, the existing Optum healthcare network that Optum has. Following this, we would recognize synergies and complementary goods that the mobile clinics already have. For example, I do know that Optum does have the Rally app, which is also up and running right now, which we could use in conjunction with the P2P application. Combining the advertising of Optum Health and United Healthcare, we would be able to bring this to the market. And after we've collected the necessary data that would help us enhance our user interface, we could actually use this to enhance the care at the rural clinics. I'm now going to pass it to Sumit to sum up the costs for the P2P application.
So yeah, the markets that we are trying to penetrate here, the mHealth and mobile health and the telemedicine, both have compounded annual growth rate for more than 25% for the next 5 to 7 years. That puts telemedicine market alone at $400 billion by 2027. The solution, the all-encompassing solution, isn't that heavy on the cost. So the cost of building the app is $50,000 each for Android and for the iOS. But we would also like to add a hotline to it, as Anju pointed out, so that the people with lack of internet access and who are not that tech-savvy could also use our solution and the benefits that our services provide. So that brings in additional cost of around $55,000 per year for staff. So, but the beauty of this is, like, when we go from pilot phase to the deploying into the larger scale, then the costs incurred are not that high because we are leveraging technology in this. The only additional substantial cost would be of the staff, but increasing staffing costs would only be indicative of increasing traffic on our platform, which I think would be a good news.
Yeah. And we just want to thank everyone for coming out. We know it was a long trip, but we're opening the floor to any questions that you might have.
You're clearly targeting rural individuals. Have you thought about, what would be the perception or reception of a mobile truck rolling into a town without any local partner someone that's trusted by the local community to, endorse that service?
Of course, there could be an initial backlash, but rather than just simply starting Optum Healthcare, we would be going to hospitals, for example, in Pottsville, Pennsylvania. There's the Lehigh Valley Network, which services a town of about 2,000-3,000, maybe even less, partnering with the hospital and with Optum Healthcare together. So it would be part of, if you can go back, we would definitely bring it up in 6-month pilot program as we're recruiting the necessary healthcare staff, hospitals, nurses, doctors, and the institutions.
Can I just clarify some of my understanding here? You guys really want to build an app that locates and identifies resources that might already be available, like Lehigh clinics, right? Or something like that. You're not planning on spinning up and operating your own mobile clinics, or are you?
No, we would be.
Okay, got it.
Right.
So I do have those sort of basis of understanding, make sure I got that right. So to what extent have you guys kind of thought through the logistic realities of scaling that? A lot of health systems even have trouble creating their own clinic locators because, clinics open and close all the time, or getting the data sorted. You're now working with a bunch of discrete external partners. How do you sort of manage that from a logistics standpoint?
And they move.
And they move. They move. Right. My local brewery can't even keep track of what food trucks are where, So what about sort of the logistical challenge behind identifying all these, keeping track of them, keeping the data current?
Yeah, no, the initial thought would be similar to how, Uber drivers accept rides, things like that. The clinics themselves would have their app set up, accepting and having their location on, knowing what's available, what services are available, what type of care that would be provided there. So they're going to be in charge of kind of turning on and off, whether they're available and where they're at.
So you talked about veterans, substance abuse, food access, Medicare enrollment,
Pharmacy.
What's the number one issue facing rural communities if you had to pick one thing from the data that you curated? And second question is, what's your definition of rural?
15% of the population. So what we're trying to look at, we use that map and the data that we had to pinpoint different locations like the U.S.-Mexico border, Appalachia, tribal communities. Those were kind of our target locations. We were going to slowly roll that out to those areas. I think based on the data we've seen, that's kind of where we want to pinpoint rural. Again, it's very broad. There's a lot of data and research out there that's done and programs that are available based on the definitions through these different agencies. So we kind of want to pinpoint one of those regions.
Then that's you think is the most important for rural,
The most
given that it's such a broad definition. of
Right. The
rural.
most important issue is just the simple actual lack of basic preventative care at the time in primary care. If and for example, I can use possible Pennsylvania just from the top at being there recently, you have maybe one plastic surgeon covering the entire area, only a few doctors and nurses, but at the same time, there's no clinching reason to keep them there. They're going to go where, unfortunately, in many cases, where the money is. And it's not going to be in those areas. Lack to that single internal medicine doctor, lack to that nurse practitioner is down going to drive down the entire care community. So although internet access might seem like the primary problem here, we did add in the hotline that would eventually circle back to internet access. But from what you're saying, no, it's definitely the lack of preventative and primary care just in general. Thus, bringing mobile clinics to these individuals who, I guess the second problem here is actually lack of education, both in technology and in terms of their own health. A coal miner is not going to understand that, in many cases, that his lungs are being affected by the area around him, or someone working with asphalt in many cases, going to make the simple connection, I need to go to the doctor, I can't find one, how do I look at my phone in some cases?
So this is a kind of further down the line, just this question that we have. And please correct my lack of understanding, but I think the scaling issue is just workers. We're in an acute worker shortage crisis in the whole healthcare industry, like 50,000 doctors, over like 200,000 nurses, and other providers. So if this is really tapping into the existing assets that we currently have, like if they're so understaffed over, there's no capacity to be had, how do you think to address that if it's going to grow, if there's such a huge lack of existing and growing workers?
We did work with an idea initially regarding also student loan debt for doctors and nurses, which, to be honest, every doctor and nurse has a little bit of that debt. Where working with these mobile clinics and with Up Health, we can actually help pay a little bit for their loans, somewhat similar to the student loan forgiveness program that the government had, but in this case, bring that forgiveness through the mobile clinics to the facilities that need them. And at the same time, we actually thought about, again, given the shortage, some sort of rotational like program working with hospitals that we can bring those doctors to those communities. Lehigh Valley is an example, just from my recent memory. But yeah, those were two solutions that we came up kind of short term. In terms of bringing more doctors and nurses into the healthcare in general, that's going to be something that probably is out of the scope of this solution. But those were the two initial things that we actually had.